Okay, welcome everybody. Share my video. Okay, if you guys could do me a favor and somebody just post, can you guys see my screen here? Good, 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 okay. And can you hear me okay? Great. Okay, I am recording this here. And I'm going to go ahead and just jump into how do we scan for an MRI routine brain. What you all will want, and I'm showing you here this paper of the practical requirements. This is what you are going to want to bring when you come in for your open labs, because you can take notes on this. We're going to go through each of these numbers, number 1, number 2, number 3, because technically these are all 4 different types of pulse sequences. And you can write notes as we go over this here in the lab lecture. So when you come in for your practice of your 2 one-hour labs, you can bring this with you and look at it and practice setting up. For your practical though, you will not be allowed to bring in your sheet with your notes, but this sheet will be here for you. So this is basically your exam. And what you will want to see or want to recognize is there is an MRI Brain without. If we flip it over, this is the MRI Brain with and without for MS. So depending on whatever order you pick is dependent on which protocol that you're going to use. You're either going to do a brain with and without for MS, or you're going to do a brain without, okay? So I am going to be following this paper in today's labs. And if there's ever any questions, go ahead and just let me know, okay? So the very first thing, and hopefully by now you guys have all had practice time on your computer. So when you have your practical exam and you're going to type in your patient's information, you're going to go up to patient, you're going to pick new exam, and then you are going to type in your patient's name. So I'm just going to use my name. It's not allowing me to capitalize that there, but the registration ID, do not worry about. In the real world, many times your registration ID will be your medical record number, okay? So I'm going to have you just put in your patient's name. The date of birth is going to be the date. And notice that on this Phillips, you have to type in the month. So let's just say January. And then the year. And then type in whatever year. Let's say 1969, right? Oops. Okay. So that's how you would type in the date of birth. Is your patient a male or a female? And what are you scanning? So you can just type in brain. The accession number will be the accession number that's tied to your exam. So again, in the real world, that will populate for you, so don't worry about that. It'll have today's date and the weight that you put in, where you're going to look at this chart. And we look at, the Phillips has it in kilograms, so therefore you're going to look at the kilograms and course are the pounds, and you're going to correspond it to the kilograms. In lecture, remember on the very top, I was talking about the contrast. And this is the contrast that you would be using if you're going to give contrast, okay? So we'll just go ahead and let's say in my dream, I weigh about 110 pounds, right? So that comes to 49.5. I cannot put decimal points in, so I'm going to round it up to 50 kilograms. My referring physician will be what's written on my order, so it might be Dr. Smith. The performing physician we won't put down. You know, in the real world, sometimes you have a referring physician might be your family doctor, and then the performing physician, it might be a specialty doctor, or maybe the performing physician would be your radiologist that you would be putting on. But for our practical purposes, we are just going to write the doctor's name that has that's written on the order. And again, I'm just going to put down brain here. Okay? In the real world, your exam name might be a lower extremity, and then in your comments you're going to want to put down like a left knee or a right knee or so forth, because many times these comments will actually be populated into your MRI images, and this way doctors can look at it quickly and say, is that a right knee or a left knee? Okay, so if we look at our practical requirements, the exam in your computer that you're going to pick is the Owens Essential Brain Planning 1. And I'm going to click Proceed. Okay? Now, if this pops up, that just means that it didn't clear out. Maybe the person in front of you, you know, if it didn't do a shutdown, it didn't clear it out appropriately. No big worries. You can always click yes. And then sometimes, like, whatever the last thing that was done on this computer might pop up. And so I'm going to go ahead, and if I click on it and I highlight this orange and I do a shift and I do the bottom, all of these become orange. I can do a right mouse click and I can cut this out. Okay? So over here, you have protocols that the actual Philips company has put in here, okay, and there's protocols for many of the body parts, but the places that, you know, you are going to be going to clinic at, they've already built their protocols for that particular hospital, okay, so we can go under the hospital tab, and it pops up under heads, but if I go back, it'll populate into, okay, what protocols do you have for your cervical? What protocol for your head? What protocol for lower extremity, and so forth. So I'm going to do my head, double click it, and these are all the protocols that I have listed, or that I actually built in here. So we have a brain with MS, with and without. I have a routine brain without, and then here's a routine brain with and without that maybe is not for MS, okay? Maybe it's for some other kind of an indication. So we're going to start with the MRI brain without. And if I click on this and just drag it over, I've now loaded my protocol for this particular exam in, okay? So the very first thing I need to do is a survey. I'm going to click on that. And if I go to my pencil here, I can load and look at what kind of protocols that this survey is loaded on. And if I look at my coil selection, okay, I notice that my sense head is connected. If I click on this, and if I double click my survey, it'll actually open it, okay? So by opening it, then I can, let's say I have my sense head coil, which has 8 channels to it, okay? But if by chance I changed my coil and the computer did not recognize it, I can tell the computer, okay, you need to go ahead and, you know, turn on this other coil. And I'm trying to think, I don't know if there's another. Here is the sense head, which is 8 coils. There is a sense head that has 6 channels. And it looks like that's all the coils that are listed. And this is just a routine head coil, which is probably maybe what your QA testing might be done on. But we're going to go back And this is where, it should populate for you that the sense head coil is on. And anytime you pick something, you're going to have to hit enter so it takes it, okay? So the sense 8 coil is on. I just want to run a 3-plane survey or pilot. They're called kind of interchangeably. I'm going to click proceed to download this protocol. This protocol is only going to take me 17 seconds, okay? If you look here, in this box is where I can change parameters. In this box I can't, but by changing things over here will change the different types of, matrix, voxel size, and different things like that. So, but this is where my total scan duration for this 3-plane survey is going to take me 17.4 seconds. I'm going to download it, and then I can go ahead and start my scan. Now, what I want to see for you guys and Brenda for your practicals is that you're talking to your patient, right? And so this is what you're going to be doing to talk to your patient. So you're going to need to turn it on. And I did not turn on the gantry here, but we're going to turn it on here, and then I hold this button down to talk to my patient, okay? So anytime that you want to talk to your patient, I suggest you do it the very first thing when you come and sit down at your computer, and you tell your patient, and let's say my patient's name is Mary Jo. I'm going to say, Mary Jo, are you doing okay in there? It's just going to take me about a minute here to get things set up, and then we're going to start with our first picture. This way, your patients know that you are right here all the time. And it kind of gives you a sense on how is your patient doing in there. Are they nervous? Are they scared? Talking to your patient right off the bat will ease their anxiety, okay? So I have not started my scan yet. I only clicked proceed, which downloads it. So if I wanted to right now, I could say, okay, Mary Jo, this first set's going to take about 17 seconds, so just hold real still. Once I click start scan, in the real world, it's going to start with the knocking sound, and it's going to run for 17 seconds, okay? So that's done. And in order to load my 3-plane pilot, you need to look over here at your scan box, okay? And you're going to click on the plus sign. I want to add those scans into my viewport. And we call each of these a viewport, okay? So if you notice there's an orange line, I'm on the sagittal viewport. Here now is the coronal, and here's the axial. And I don't have to have sagittals and coronals and axials here. I could put my coronal here, I could put my sagittal here and my axial, or I can put my axial here and my sagittal here and my coronal here. It doesn't matter how you have these, but what I suggest is, because you have 3 planes here, that you have one plane of a sagittal, one other plane of a coronal, and another plane of a axial, okay? So if you click on this, you can then, with your little, I'm going to show you here. I just magnified these by, and I'm trying to show you, by clicking the middle and holding down the right together. If I hold both of these down, I can magnify these images, okay? So I can make it bigger or smaller depending on how I want to view this or look at it, okay? Now, when we do these 3-plane pilots, not only am I getting only one sagittal and one coronal and one axial, if you look over here at the vertical bar, in scan 1, I can go up And notice I have a sagittal, a sagittal, and a sagittal, and a coronal, and an axial, right? And however you build these protocols is really up to you. Some places might do 5 sagittals, 5 coronals, and 5 axials, and they'll get 15 different pilot images. And then you pick which best one you want to use. But in some people, some places might only do 3, 3, and 3, or they'll do 3 sagittals, 1 coronal, 1 axial. Your 3-plane pilot is basically taken at isocenter. So it's really 0, 0, and 0, right? So that's why it's crucial to go ahead and localize and put your body part at isocenter, and also to make sure that the head is straight, because then you'll get a perfect sagittal right through the nose, and then there's your lips here, and then you'll get a nice coronal and a nice axial. Okay, so the next thing that in this protocol here is a reference scan. If you double click it, basically what you'll see is the entire field of view is all lined up with red lines. And anytime you're utilizing a sense coil, which means we can do parallel imaging to make faster scans if we need to, I have to do a reference scan. Some sites or some vendors call it a calibration scan. You do not have to change anything. All you have to do is click proceed and then start it. And this one is about 1.5 minutes, so you can start that. On these new scanners, your survey and your reference scan are done at the exact same time. So you necessarily don't even have to do a reference scan, but I do, I put this out there because, again, anytime you want to use parallel imaging, you have to do either a reference scan or, like I said, some places call it a calibration scan. So therefore, if that wasn't done and you tried to turn on parallel imaging, you would get that error message, and then you just would have to make sure you run it, okay? So that's kind of why I add that on. So my survey and my reference scan are done, right? Now let's look at our practical requirements page, and under Brain Without, the very first protocol I'm asking you to set up is a T1 sagittal spin echo, which is this one, T1 sagittal spin echo. If I double click it, okay, then you're going to notice I have a field of view box over my sagittal, because that's what I'm setting up, right? And then I have lines that's being projected onto my coronal, my axial. So if I look at my tabs, my initial tab basically is kind of like a snapshot of protocols. I got my coil selected here. I have my field of view. I have the voxel size, slice thickness, my fold over direction. Your fold over direction is the exact same thing as your phase direction, because what direction will fold over or wrap? It's an AP. So therefore, that is my phase direction, okay? And then it has TR and TE, and it has NSA. Don't worry about the preparation phases here. But all of these initial parameters you can find elsewhere in these tabs here. Any parameter that changes the geometry of your image, field of view, voxel size, slice thickness, gap, your number of slices, 22, your fold over direction again is here. That all is under this geometry tab. Contrast, well, what changes how your picture looks? Your black and white, right? That's under the contrast tab. And for now, what you're going to want to concentrate on is TR, TE, and then eventually I'll talk to you about our turbo spin echo or our fast spin echoes, okay? So that, by changing TR and TE, that will change how my pictures look, black and white, right? I can either make CSF dark or I can make CSF bright. Over in the motion tab is where this NSA is at. And NSA is the exact same thing as NEX, N-E-X, or your number of acquisitions, okay? Because this will basically is our coats of paint. And the more NSA you have, the prettier picture's gotta be. But the downside is it's going to affect your time. And we're always balancing resolution, signal, and time, okay? So let's go right off the bat to the geometry tab, because I'm telling you to select a field of view of 240 by 240. Notice your field of view actually has 3 things to it, okay? Well, if I look at my field of view here, I can change the field of view in my head to foot direction, and I can change it in my anterior to posterior direction. The right to left direction is basically that third dimension, because remember, we are doing even though we only see 2-dimensional images, we are doing a 3-dimensional type of picture. That third dimension basically is your field of view with how many slices you have. So if I take down here the slices, and if I change my slices to 35 and click enter, notice how my right to left dimension, which is here, changes. And it only changes because I added slices. So as far as field of view goes, only, I'm going to go back to 22, okay? Only look or worry about the field of view in the 2 dimensions that you can see. Going back to my sagittal here, okay? This is my field of view box. I can see head to foot, and I can see A to P. So these top 2 are the only things I'm going to be interested in. I'm not worried about this dimension because I'm going to be doing that down here in the slices when I'm looking at this viewport and this viewport. So I'm telling you to do a 240 by 240. So I'm going to plug in 240 by 240. This is the field of view that I want to use, okay? Now, on this particular patient, because everybody's head size is different, right? And I'm making it easy for you, far as I'm telling you what to plug in. Could you have used a 230 by 230 on this particular patient? Is there any head anatomy outside of the field of view that we're missing? No. You could have used a 230. Could you have used a 190? If I use a 190, first of all, I'm cutting off my nose, and I am pretty tight here with this, skin fold. And if I have my phase direction going A to P, I have to worry about this nose wrapping into the back. So this is a pretty tight field of view here, right? So this is where at some point next semester, where I'm going to be telling you, pick your own field of view. What do you like? What do you think would be a good field of view? Notice that as I go with the smaller field of view, I'm going to go ahead and decrease this signal here. This is my relative signal percentage, okay? But the smaller my field of view, the better my resolution. And that's again where you're going to be balancing. I got to balance the signal I'm losing, but I might get better resolution. But yet I still might get a pretty picture because I have a good coil. So that's the balancing act that eventually you're going to do. But all I'm going to ask you to do for this practical is to do a 240 by 240. And I'm going to position my field of view box then pretty much in the center of the brain, which is right now right over this thalamus, right? I don't want my field of view to go here because now this is the center of my picture. And I really don't want my field of view to go here, because now as the radiologist is looking at these pictures, my eye is going to be at the center here. I really want it to be in the center of my brain. So I'm going to put it right over where my thalamus is at, which is right underneath where your corpus callosum's at, right? Now, if you position it here or you position it here, is it a big deal? No, it is not a big deal, okay? But it's just the fact that you want your field of view to be hung up for the radiologist where their eyeballs are going to go right in the center of where they're looking at, right? And in this particular patient, this patient's head is pretty well straight in this plane. If by chance you had this head tilted way back, like on some real kyphotic patients, you can now change the angle of how you want to hang the head up by changing your field of view. So I kind of look at my field of view box as my picture frame. How do I want to hang it on the wall? How do I want this brain to show up for the radiologist to view, right? So, you know, sometimes you're going to just let it straight. Sometimes you might want to angle a little bit. And then what happens then is this particular head, this picture will be slanted this way for the doctors to look at. So hopefully you understand that. But for you guys, we're going to let it straight, okay? I'm telling you to pick a slice thickness of 5 millimeter. So under geometry, and if I scroll down here, I can pick a slice thickness here of 5, and it's on 5, with a 1 gap. And if I go down to my gap, it's already on 1. But I want you to always be looking for this, because I can save it and I can change it to 3 if I wanted to. And then when you pull this up, you're going to say, well, it should have been 5. It was 5 last time. You really do want to be looking at these to make sure that it is at 5 at 1. Okay? And I'm even telling you that's on the geometry page. So you have your geometry set up then how you like it. I like my field of view, I like my slice thickness, and I like my gap, right? So I can, if I want to, go right to setting up my slices. And I want a slice to go right down through the longitudinal fissure on this axial and right through this falx cerebri on this coronal, right? Now, if you go over to where it says your lines here, I can turn off, these are all of my individual slices. Notice it says 1 through 22, and the 1 I'm starting on the left side and I'm slicing through to the right. If you do not want to see these red lines, I can turn them off. I can click on this and say, I only want to see the first slice, the middle slice, and the last slice. This is kind of nice to do, because now what I can do is I can say, you know what, I need to angle and use almost your middle slice as a ruler. Notice now I am going to cut through the very falx cerebri, and this is almost into where my pons is, so I get a true sagittal from the right side of the brain to the left side of the brain, okay? Also, I can use it on this one, and I can say, do I need to angle this? If you wanted to do a slight angle, you can, because again, this is 3-dimension, so you can angle off of both of these planes. And anytime you do angles like that, you're going to kind of just get a little bit of a different line going through this field of view box. But don't worry about it, because you still got it nice and square. You set it up originally. And then you're going to go over here and do your angles here. So if you get these angles the way you like them, you can then go back and turn your slices back on. Okay? Or you can set them up just with the red lines on them, and that's no big deal either. if you like your coverage, if you think you have all of your slices on and you're going to get through the entire brain, you can leave it. It says 22 slices. Or here's where you say, you know what, I might need an add a slice, or I can decrease a slice. You can add, 24. You notice here that I'm just covering more from left to right. Here's one thing to think about when you're setting up a sagittal. Because we're trying to kind of cut anatomy and basically break it from, right to left side here, I like to use an odd number. And the reason that I like the odd number then is because now my middle slice is going to go right through the center, and I will have an equal number of slices on this side and an equal number of slices on that side. That's just my pet peeve. You could let it at 22 and it is no big deal. You could still do that as well, okay? So that is something that's really your preference. So it's at 22 slices if you like that, and we're covering this pretty good. Then you can go ahead and say, okay, I've got my right field of view, I like my number of slices, I like my thickness, and I like my gap, okay? Now go to B and say, okay, change my TR and TE to appropriate parameters for weighting. Well, I want a T1 sagittal, right? Because that's what it's telling me there. Set up a T1 sagittal. If I go to my TR and it's on range, it says that the minimum TR I want to use is 450. The maximum is 650. So it'll pick a TR between this. If I go over to the actual TR that's going to use with this number of slices, it says I'm using a TR of 596 and a TE of 15. Does that give me T1? What do you guys think? Does it give me T1 if I pick a TR of 596 and a TE of 15? What do you guys think? You're telling me no. Christopher, you're telling me yes. And I apologize if I haven't been reading on your comments here, only because I'm looking at the scanner and I'm not looking at the laptop here. But yes, Todd. And I need to go ahead and take my speakers. I think my speakers are muted. So let me turn it up. Okay, what you need, Todd? What's your question?
I just, if you could hear us okay, there was a couple of people trying to ask you questions. You haven't responded.
Yeah, I am so sorry. I can hear you now because, like I said, this is the first that I looked back at my laptop. But yes, what questions? Let me scroll up here. Okay, what questions are people having? Because I want to make sure that I answer these for you. Shalika.
Okay, can you hear me now?
I can hear you, yes.
Okay. Okay, my question earlier was just about the TR numbers, because the TR and TE numbers, because since we've been practicing, she's been telling us that it's solely up to you, but we haven't heard anything like what numbers you want us to do. So that was pretty much my question, but you kind of got to it right now.
Yes, okay, yep, that's okay. Now, I'm not real sure like how far you are in your other classes with in physics, like with TR, TEs for T1 weighting and even for T2 weighting, but what most places will do is a TR for a T1 weighted image is going to be less than 800. So I would say a TR then of 596 Yes, Shalika.
Can you repeat that one more time? I'm sorry, I was trying to find my pencil.
Oh, God, that's okay. So for a T1 weighted image, you want a low TR and a low TE, okay? So a low TR would be 800 or less, and a low TE would be 30 or less. So now, what you pick though can be up to you, and it's going to dictate with how many slices that you have. Because the number of slices that you can get within a given TR is dependent on the length of that TR and the number of slices. Okay? So a TR of 596 is less than 800. A TE of less than 30, we have 15. That's going to give me T1 weighting. Does that make sense? Now, and that's on range, if I take my TR and if I change it to user defined, I can tell the computer what TR I want. So maybe I'll say, you know what, I want a TR of 400. Okay? Notice that my time went up because, let me hold on here.
So that'll be something that you guys will tell us during the scan, correct?
No, that's something that you need to know. Whereas if you pick a TR that is 1,000, is that going to give me a T1 weighted image?
Okay, yeah, because they said that you guys would tell us and that we weren't supposed to worry about it until, like, you guys tell us the numbers you want us to use.
No, I really want you guys to.
That's what Cindy said anyways.
Yeah, you should. Have you guys been given any ranges at all yet for TR and TE? For T?
No.
Yeah, we went over some ranges, but they didn't tell us that we needed to like know it, rather should I say, like we didn't memorize it. I have
Okay.
it written down from the summer.
Okay.
I didn't memorize it.
Right, okay. Well, what I want you guys to know, okay? I don't want you at all to worry about your scan time yet, okay? Because we're gonna, eat this elephant one bite at a time here. So however you manipulate like these numbers, don't necessarily worry about the time yet. Because at some point we're gonna say, nah, that's a little bit long, too long of a time. What else can we adjust to make it a quicker scan for that patient to lay there, okay?
Can you please repeat what, for a T1 weighted image, the reference for the TR to the TE of what we would select?
Yes, and here's what I'm also gonna do is I'm going to upload the preferences for you, okay? Because for a T1 weighted scan, you're gonna want 800 or less TR. For a T1 weighted scan, you want a TE of 30 or less. Now, once we get to the T2, a T2 weighted scan has a high TR and a high TE. That's going to change the contrast of our pictures, right? So for a T2 weighted image, you want a TR of 2,000 or higher, and you want a TE of 80 or higher. That makes
Thank you.
you
Yes. And then, so like during the practical, when we're changing the TE and the TR,
Yep.
as long as we have it in somewhat of that range,
correct.
that would be okay?
Correct, yep. Because that's what I want you to understand from the get-go is just that, like what ranges should we use. So if you would pick, if you let it on range, okay, if you're looking at the screen, if you let it on range and it was at 450, between 450 and 650, so you're telling the computer the minimum TR I want you to use is 450, but the maximum is 650. Would that work? Yeah, that's going to give you low TR. If I go ahead and I pick with my TE, I can say I want to use the shortest TE that I can. Well, the shortest TE that I can pick with all of these parameters I have with these slices up here is an 8. Over here it says 8. And does that give me T1? It sure would, because it is less than 30. Now it was on user defined and it was set at 15. That's still lower than 30, and yes, that'll still give me T1. Now, eventually, we're going to start to get to the point of, well, what is the advantage then? There are certain advantages why you want a certain type of a TE and a certain type of a T2 because of the type of picture and the signal that you're going to get. Chelsea, did you have a question?
Yes. So, when we would go to the contrast for the TETR, if it's already like automated to where it's in the range, would we just verbally say, right now I would check the TETR to make sure it's in the appropriate range for the T1 sagittal, and then could we leave it if it's in good range?
Absolutely.
Okay.
Yep, absolutely. Yep. But it's that I just want you to recognize where they are at, and then to recognize of, hey, is that the range or not? Okay. Notice I'm going to go back to geometry because I'm just, and this is where I want you guys to, as you are practicing, you can kind of play a little bit, because here is where, if I go back to geometry, I have a TR of 596, and if I change my slices to 30, then what happens is the TR over here says that it's going to go ahead and use 450 TR, but it needs to do it in 2 packages, which means, let me go back here. That means that I can get all 22 slices with a TR of 596. If I need to do 30, it says I cannot get 30 slices in 1 TR. So it says now what I'm going to do is these packages, it says I'm going to do 450 TR, but do it twice, which means I'm going to do 15 slices and 15 slices. Okay? So, that's kind of just where you can start playing. I'm not trying to confuse you at all. Make it simple, okay? But that's kind of what I'm just trying to show you is as you change things over here with slices, it might then dictate what TR you're going to need. Hopefully that makes sense, okay? So once I get my TR in the range that I want a low TR and a low TE, and this looks good, and I have it set up the way I like it. If I look at C, all I'm saying is, tell me what phase direction you have. And I can either go to my geometry page and it'll tell me my fold over, or I can go to my initial page and it'll tell me my fold over, and I can say I want to go A to P. If by chance this was created where it was foot to head, and I'm going to change it to foot to head, that means that anything down here is going to wrap up here. Okay? But I want A to P, and this is where you can swap them. And we call that, we can swap phase with frequency. Because right now my phase direction is A to P, my frequency is head to foot. So all I'm asking you to do is now to state your phase direction. You can set, for D it says set up your slices appropriately, and we actually kind of did that already. And if you like how this looks, you're good to go. Once you click proceed, what that says is it's going to download it and you're ready to start. So then I can just look and say, well, this particular set of pictures, this T1 sagittal spin echo, is going to take me 4 minutes and 17 seconds to acquire. So I could proceed, and then I can tell my patient, okay, Mary Jo, this next set's going to take about 4 minutes. Here we go. And once you click start, it's taken those pictures. Okay? Now, once you click this proceed to download it and you click start, if you did anything wrong in this setup, that is an automatic failure. Which means if you, let's say you had your slices set up like this, and it's not in the way it's supposed to be, and let's say, you know, your field of view, we're just gonna make this really whopper jawed. If you set up like this, and I clicked proceed and start, then I would have to stop you and say, okay, let's pull this back up. Is that really how you wanted to scan this? Does that make sense? That would be an automatic failure. Any questions on that?
No.
Okay, good. So that's how you set up number 1 for a T1 sagittal. Number 2 is the diffusion scan. Now, we didn't get to that in lecture, but all you need to know for a diffusion scan is, 1, it detects the movement of water. 2, it is the best pulse sequence to pick out an acute or subacute stroke. Okay? It is an echoplanar type of pulse sequence. It's very quickly done. We can get them done in under a minute, okay? But all you need to do with setting it up is, says DWI, stands for Diffusion Weighted Image. We're going to double click it, okay? And some sites will tell you to scan it straight. Do not angle your diffusion scans. Some of our new MRI systems, we can now scan an oblique diffusion, okay? But for simple purposes, all I need you to do is to pick the field of view that I'm asking you to, and this is an axial. So if I go to my axial viewport, here's my axial field of view, okay? I'm telling you to pick go to geometry, 230 by 200. So I want, notice how I'm longer anterior to posterior and I'm shorter right to left, right? They call this the long axis and the short axis. So I'm going to take my right to left and change it to 200. Notice that sometimes it'll change both, but then I'm going to go back because I want my A to P to be 230. Notice how it makes a rectangular field of view, right? Because by doing this, it's just going to allow me to scan faster because I'm not sampling anatomy, or not even, there's no anatomy over here. I'm not filling case space with nothing, with zeros. So I'm telling you what field of view to pick. 230 is going to be in the AP direction. 200 is going to be in the right to left direction. Slice thickness is 5 at a 1 gap. And if I scroll down, I can see my gap here is at 1. Okay? I'm telling you, this is a specialized protocol. You do not have to change TR and TE, but just tell me what is it. If I go to my contrast page, my TR is set on shortest, which if I look over here, the actual TR is 3,624. My TE is set at shortest. If I look over here, it's 115. So somebody tell me, if I have a TR of 3,624 and a TE of 1,115, excellent. That's going to give me T2 weighting, isn't it? Perfect. Okay. This is an EPI pulse sequence. Okay? So do not need to change anything with TR or TE. But what I do want you to do for C is verify the max B value. So under my contrast, if I scroll down, I have a max B value of 1,000. You don't have to change it here either, but I just want you to know where it's located. For diffusion weighted pulse sequence.
Where did you say max B value is? What tab's that under?
It's under contrast. And if you can see on the computer, it's down here. You're going to have to scroll this bar down. And it's under max B factor 1,000. Can you see that where I'm pointing it out?
I mean, I can see where you're pointing, but it's really hard to read.
Yeah, okay. I'm going to try to magnify this up here for you. So it is right here. Max B factor.
Okay, I can see it.
Yep, 1,000. Okay. So all you now have to do is position your slices. Now, I already took a T1 sagittal, didn't I? I can now use these T1 sagittal images to go ahead and get a better looking sagittal. So if I go over to my scan box, and if I go ahead and just slide this over to my scan 3, and then this is my sagittal that I just took. And is not that a prettier picture to set your images up off of? It is, isn't it? So one thing to keep in mind that as you scan through a protocol, you can always replace what is in these viewports with better looking pictures, because you can utilize those pictures to help you set up your slices. I would much rather set my slices up on this sagittal than I did on my first sagittal, because this one's pretty grainy. It's just a very quick snapshot. But it was good enough to get my, my first set of sagittals, right? It was good enough for me to figure out what field of view I wanted. But now I want to go ahead and pick a prettier sagittal. And again, if you just page down through this vertical bar, I'm going to go through each of these sagittal slices till I get to the center, which is about here, right? Now I can see my corpus callosum real nice. I can see the very tip of my cerebellum here. And if I take these slices, and I want to make sure I get the entire brain on it, so I don't want to miss. I don't want to really take my first slice right away in brain, because I don't want to miss anything, right? So I'm going to bring it down a little bit. And do you feel like I need to add any slices for this particular diffusion scan?
Don't you usually want to get part of the spinal cord in it?
For the brain, you don't have to. Not on these axials, nope.
And then do you have to angle it on the corpus callosum? I know you have it like in the middle, but...
Not for the diffusion. We are only going to angle for number 3 and number 4. Okay? So for the diffusion, we're going to do these straight. What I'm telling you, what I said earlier though, is in the past, that is how we always did our diffusions. We just did them straight. Now, there are some sites or some, because the way diffusion data is collected, it uses bipolar gradients, and now we're getting into the physics portion again. But because of how the data is collected, they don't want you to angle. Now, on the new systems, they have configured it where you can angle on diffusion weighted scans. Okay, just to clarify that. So basically, all you're doing for this diffusion is you're going to set it up, and you're going to go ahead and change the field of view. You're going to make sure that this field of view box is going to be in the center, in the very center of the head. I'm going to put this around that third ventricle, right? I wouldn't want to scan it like that, because I'm not going to get any information back here. And I really don't think I'd want to put it like here, even though I'm going to, I'm not cutting that part off, but then the middle of my, really what I'm looking at in the center, I'm not in the center of the brain. You want it to be in the center of what you're really looking at, okay? If you don't have to add slices if you don't want, because we're pretty much right at the top, or if you feel like, you know what, that's pretty close, and if you want to add a couple slices, just go to your geometry page and add a couple slices and then say, yeah, okay, I'm all the way through. I'm into the skin here. And with the diffusion, I'm looking for an acute stroke, okay? So we are done with setting this up. It's only 47 seconds. Proceed and start. And now you're going to run that one. Number 3, I'm going to set up for a T2 axial turbospinecto. Now, there's a T2 flare built in here, but I'm not asking you to set up a flare. I'm asking you to set up a T2 axial. So go down to this here, double click it. It's going to bring it up for you. Okay? So now is where I'm going to angle with the corpus callosum. But the very first thing is I'm telling you to do is let's do a field of view of 230, right to left. I'm going to make that 200, right? Because I'm going to make, again, a square field of view. Slice thickness is going to be 5. I'm going to change this from 4 to 5 at 1 gap. Perfect, I got that done. So if you want to go to contrast and start to pick your TR and TEs, you can, or you can say, you know what, I'm going to set this up real quick. I want to angle, and if you want to turn your red off, you can turn those red slices off, and you can say, I'm going to angle and draw a line from the splenium, or I'm not splenium, the genu to the splenium here. That's going to be parallel, right? I'm going to slice right through the center of that. Whether you are here or here, that's minute. Don't worry, it doesn't have to be like, I'm not going to go within 5 degrees of one or the other. But this is the angle you want. Okay? You can turn your slices back on now. And these are the slices that you're going to cover. Here's my field of view over here, right? If you need to straighten this up, you can always move this up or down. If you feel like you want to straighten it, go to the edges and straighten it there. Look over here at your coronal. Do you think you're going to be taking a slice axially right through here and it's going to be equal? The head's kind of tilted, isn't it? So what I would do to get a good, perfect axial then is to angle it where I can get a slice that's going right through, or remember how let me pull up something here. Remember when we set up our sagittal going right through here? Through that falx cerebri? Let me show it in a different way. So we set our sagittals up like that. So if you had to angle your sagittal to get a perfect sagittal, then you're going to have to about angle your axial to get a perfect axial. Otherwise, your axials are going to be like this. So hopefully that makes sense to you. Okay? So once I angle this off of my coronal here, I know if I put my slices back on that I need more slices because again, I want to be starting out in my foramen magnum, And I'm actually not all the way through to my vortex. I'm not even to the skin, am I? So just go to your geometry and add some more slices. Maybe let's add 3 slices. And then I'm going to go ahead and position it. I'm into my foramen magnum. I've also got all the way through into my skin. And if you even want to double check, if you go and click on your viewport and you page through these, you can even see through all of your sagittals. Okay, yeah, that's looking pretty good, isn't it? So you can use all of these sagittals to help make sure that you're not cutting anything off. Okay? Again, I'm just asking you to go to your TR and TE. It's at 5,049 with the TE of 100. Is that a T2 weighted scan? Yes, good job. Now, the turbo factor, because this is now a turbo spin echo or a fast spin echo, the one other parameter that I want you to look at is your Tsc factor, okay? So, I'm going to give you ranges. A Tsc factor for a T1, you want to be from 2 to 4. For a Tsc factor for a T2, you basically just want that to be probably like 15 or higher. So for this particular practical, if you have a 15, that's fine. If you wanted to change it to a higher turbo spin echo factor, and I go to 20, before I click enter, notice what it does to my time. I'm going to make it faster, okay? So the higher you go in your turbo spin echo factor, the faster your scan. Now, there is some downsides by going too high, but we're not going to go there yet, okay?
I have a quick question.
Yes.
Okay, so I just want to make sure I heard you correctly. So for the TSE for T1 image is 2 to 4, and then T2 is 15 and higher?
Yes. Yep.
And then for the T2, like 15 higher, how high does that go?
Well, there's a point where if I would even try, you can play, if I go to 40, it's going to give me a conflict. I get these red things. It says you cannot use that many echo trains with what you have set up, with all these other things that you have set up, right? If I type in 30, it'll allow me to go 30. It drops it down to only 2 minutes and 11 seconds, but there's a downside to this. So that's kind of why you want like what we call a sweet spot, okay? And we're gonna talk about that farther down the line. Hopefully that all makes sense to you. So once you have your slices, this looks good. I got the angle I like. I like my field of view here. I like the TR, the TE. My phase direction, well, if I look to my field of view, I can have a phase direction of A to P or a phase direction of right to left. And remember in lecture, I want a phase direction for my axials of the brain to be right to left because of possible eye motion, okay? I don't want eye motion going down into my brain tissue. I want it to stay up anterior here. So you want your fold over direction to be right to left. We've already set up our slices. Looks good. You can click proceed and start. Okay? Now, for number 4, is I'm telling you to set up for a T2 FFE, which is the exact same thing as a gradient, okay? Phillips calls it fast field echo, but it's the exact same thing as a gradient echo. When you double click this, you are going to set up your slices, your field of view, you're going to angle it identically to what you did in step number 3. So that should be very easy to do. The same field of view, the same number of slices, the same thickness, the same gap. You're going to angle it with this corpus callosum. You're going to set these all up identical. The only thing that you are going to have to worry about to change is to go to contrast. Everything is going to be set up appropriately for you with TR and TE. The only thing I want you to look now is at the flip angle, because what's the most important part of a gradient echo is the flip angle. Don't worry about TR and TE. It's already low and low, right? The reason it's low and low is because gradient echoes were developed to scan faster. It will always be low and low. So we do not look at TR and TE in a gradient echo for weighting. What we look at for weighting is the flip angle. And I'm going to give you ranges now for the flip angle. If I want a T2 weighted gradient echo, I'm going to use a flip angle from 20 to 25. If I were to use a gradient echo and I want to do a T1 weighted image here, I'm going to need to do a flip angle of 70 to 75. Okay, so when you set this last setup, you're going to set it up exactly how you did in step 3. The only thing you're going to do under contrast is come here to your flip angle and you can change it to 20. Or if you said, I want to change it to 23, you can change it to 23. I gave you anywhere between 20 to 25 here. And you are good to go then. Proceed and start. And you've now set up 4 sequences. We did a T1, a diffusion, a T2 axial, and a gradient echo axial. And now you are done with your brain without. Does that make sense to you? Okay, good, good, good. Now, if we turn this page over, or to the next page that is brain with and without here, it is very simple here. This is a different protocol, but we're going to set things up the exact same way. I'm going to close out of here. I'm going to cut this out. I'm going to now pick the protocol that has brain for MS with and without and pull that over. Okay, I'm going to do the survey the exact same way. I'm going to do my reference scan the exact same way. I'm going to set up a T1 sagittal the exact same way that I just told you on my brain without. Now, notice number 2. Number 2 then says set up a T2 flare axial. So if I double click this, I'm going to set up this flare axial the exact same way I have set up the T2 axials and the T1 axials that we just set up and the gradient echo axials. We are always going to angle with the corpus callosum. Draw your imaginary line from the genu to the splenium. You want this to be parallel and you're going to set this up appropriately. I can straighten up my field of view. Okay? I'm telling you that the field of view I want you to pick is 230 by 200, and that 200 is going to be in that right to left direction. 5 at 1, 5 at 1 gap. Now, the TR and the TE here, I just want you to verify it to me. So I'm going to look over here, and it is utilizing 11,000 TR and a TE of 140. Remember, your T2 weighted images is what gives us bright lesions, right? And this flare sequence is because of my MS lesions. So I need a high TE because I want my lesions to be bright, right? What I want you just to identify over here, this TR/TI, that's the other number, 2800. If I go to my contrast page and I slide down, there is an IR delay. That's my 2800 right here. Anytime that you want to suppress means I don't want any signal from it, okay? you can always, for those who have to leave, I get it, but you can always watch the recording of this, okay? So for a flare sequence, anytime you want to suppress cerebrospinal fluid, you have to be in that 2000 TI range. And most places will use a TI inversion delay of about 2200, okay? So I'm going to change 28 to 2200. That is the inversion delay that I'm going to use on this flare sequence because I want to suppress cerebrospinal fluid. By suppressing cerebrospinal fluid, it's going to allow my lesions to be bright, but my CSF to be dark. That's the basic, most positive thing about this flare sequence of the brain, okay? So you're going to set up your axials then identically, and it looks like I'm going to have to add some more slices, right? So what did I add? 3 slices and put 25 slices. Position it to where I'm going to start in my foramen magnum. I'm not cutting off any part of my brain, and I'm going to end up in my skin here, right? So I have got the entire brain parenchyma covered, okay? My next thing is I said, you set it up, set up slices, and once you have it set up the way you like, click proceed and start. Number 3 is to set it for a T1 spin echo. So I'm going to double click it. I'm going to angle it the exact same way. Right with my genu or my genuum and splenium. I know that I'm going to need 25 slices because that's just what I used in number 2, right? I'm going to use the exact same slices, set it up exactly the same. I'm going to angle it over here so I get a perfect axial. I'm going to straighten up my field of view. My field of view is 230 and I'm going to change it here to 200. Okay? I'm going to straighten it up, put it right in the center there. Now my contrast for a T1, it's at 450 and a TE of 15. That will give me T1 weighting, right? I'm below 800 and I'm below 30, so I'm going to get a good T1 weighted image. My phase direction, it's an axial, it should be right to left, and if I look over here, the fold over is right to left. So therefore, that's my phase direction. I already set my slices up and I'm good to go. I'm going to proceed and start. And if you ever want to be talking to your patient, this is telling you how long it's going to take. 5 minutes and 25 seconds. So I can proceed and say, okay, Mary Jo, this next set's going to take about 5 minutes and 25 seconds. You doing okay? Yes, and you're good to go. You're going to start it. Because this is a with and without contrast, for number 4, all you have to do is say, okay, Mary Jo, I'm going to go ahead and give you that contrast right now. And then tell me how much are you going to give. And we're going to look at the chart here that says Optimart. I'm going to look at how much that patient weighs. And if they weigh 220 pounds, I'm going to give them 20 milliliters of contrast. If they weigh 154, I'm going to give them 14. If they go in between it, then just go in between it here. So if they weigh 160, I'm going to give them 15. Okay? So that's all you do for step 4 is you say, okay, Mary Jo, I'm going to give you contrast now. And then you tell the instructor saying, I'm going to go ahead and give 14 milliliters of contrast. And you're done with that. Number 5 then is just to go ahead and pick this T1 axial post and set up this T1 axial post injection the exact same way that you set it up pre. Because what we're going to then do is we're going to compare your pre-axial with your post-axial, and you want them to be set up identically with the same number of slices, right? in the same thickness, in the same gap, and you actually want the same field of view. So you want these all to be set up identically as what you did in step 3. Once you have these set up, and I'm going to be in my foramen magnum, I'm all the way through my brain here into the vortex here, I can go ahead and hit proceed and start. And then now you are done with this protocol. So that's what you do when you come in for your open labs. You're going to go ahead and practice how to do a brain without. Then you're going to also practice how to do a brain with and without for MS. Okay, because you're not sure which protocol that you are going to pick for your practical exam. Any questions on anything? I know I went over, but I kind of wanted to really go step by step so everybody can understand it. Any questions from anybody that's still left in on here? Okay, so real quick, one more thing. I want to reiterate that all of these parameters, when you're trying to understand what do I do for TR, what do I do for TE, what do I do here, that is all listed in your MRI Handbook of Scanning, that little flip book. Bring that in with you. So anytime you question something, you can refer to that and say, oh, okay, well, this here in the book says it uses a TR of this and a TE of that. I mean, that will help you. Those are guidelines for you, okay? Any other questions before I stop the recording here? Shalika.
I just want to know, when you record it and you go back to it, how do we check the recordings? Like, how can we go back to listen to this again?
Ooh, there should be a tab of recordings for you, and I'll double check with Sue Ellen, because I've personally never watched or listened to myself. But there should be a very easy way where you can just check on the recordings of this. I think it's on that left-hand side.
Okay, I'll go and check after you end this one. I'll go and check and I'll let you know.
Okay. Yep. And that would be fine. But I'm pretty sure that it's, right on that left-hand side there. I'm going to stop the recording now so it's not so long. Okay, that's why it's important to have 2 hours of practice, because I know this might seem like a lot, but the more you do it, it does just get to be second nature. And when you're looking at this, you're going to spend it's going to take you 1 minute to set it up and go. Set it up and go. And that's kind of pretty much, that just comes with practice, okay? That's why it's so important to utilize your hour lab times and practice. All right, I'm going to sign off. Any questions, always go, your open lab supervisors are going to be with you. I'm here, Brenda's here, Cindy's here. If there's ever any questions, shoot us a text so we can answer it right away for you. If you're here and, of course you'll always be with an open lab supervisor, but, they should always be able to answer questions for you. All right, take care everybody. Thank you.